my title is Unraveling the Mystery of Long COVID, and especially the role of vitamin D and other treatment options. But I'm a big fan of the Beatles, so my subtitle is I'm so tired, I haven't slept a wink. Maybe some of you recognize this. This is one of the songs of the Beatles, and I like it. So let's go ahead. So first, my acknowledgement. So I have defended patients with adverse events due to medical devices in court. Otherwise, I have a speaker fee from some pharmaceutical companies, and I have a consulting fee from others. That doesn't influence this talk, actually. And most importantly, I'm still a member of the an expert member of the screening panel for medical devices of the European Union. So my career started my research career started about 40 years ago when I was while I was a resident in internal medicine. I did do my PhD thesis, and we did the research was dedicated to vasculitis, which is blood vessel inflammation, a very severe disease, certainly at that time, because generally patients did not survive. So within 5 years, there was a mortality which was very, very high in this disease. So most often the diagnosis was made by the pathologist after death. So a big issue then was to see whether we could find a biomarker so that the diagnosis could be made easily during life. Because at that time, only biopsies of affected organs could help. And then we discovered that these patients did have an autoantibody, which is now called NK, and that with the help of this antibody, it was much easier to make a diagnosis. And then when we discovered the autoantibody, which is directed to enzymes in the neutrophils, we subsequently tested whether these antibodies could actually induce the disease, and that appeared to be the case. So we could induce the disease by immunizing experimental animals with these enzymes, and then they developed vasculitis as well. So that was a big discovery because, as you may know, that in most autoimmune diseases, it's very difficult to prove that an autoantibody actually causes the disease. So this made me some fame, I would say, because we had not only a test, but also a test that actually could predict whether the patients get worse, and also the test could be used as a pathophysiological explanation how the disease goes. So it was important to have an earlier diagnosis and also treatment we could change. In the past, patients always get long-term cyclophosphamide, one of the drugs that are being used in cancer, and that could be replaced by a specific autoantibody that targets the cells that make autoantibodies, so rituximab. And what you see here is that patients with this form of vasculitis actually had a much better survival when compared to the 90s and the 80s of the last century. So now about 75% survives long term, so say 15 years. So it's a great success story, but I was not finally satisfied. Why not? Because when I treat these patients, so the outcome is much better, and they feel okay, but generally they are very much tired, many of them. And that puzzled me because we're doing our best and we arrange the best medications for them. We even skip prednisone nowadays by a complement inhibitor, but still patients are not always happy, and quite often they feel that it's difficult to have contact with um, friends because they're so tired. So speaking about, so that was the next phase in my life, that I wanted to look at the fatigue. Why are our patients so tired? What's happening? And this is not only in vasculitis, but in many other diseases. So first of all, I started with the song of the Beatles. John Lennon wrote this song while he was in India, and he just met Yoko Ono and he couldn't sleep. So he was plagued by insomnia when he did write this song. So he was tired, and we are all now and then tired. But it's important to realize that fatigue is not the same as exhaustion. And our patients generally have exhaustion. So um, their fatigue is actually more or less extreme. And they easily felt overwhelmed, easily irritated. And this is really different than just the normal fatigue that we all have nowadays. So that's an important factor that we found, that it's important to study, especially those patients who are exhausted. And that's where we are looking now into a subgroup of patients who are tired, but they actually fulfill the criteria for what we call ME, so myalgic encephalomyelitis, or as it also is called, chronic fatigue syndrome. A syndrome that was, say, 5 years or 10 years ago, something where many people thought, well, it's all in the head of the patient. So it is not a real disease. It should be solved by psychologists and psychiatrists. However, that is not the case. So by definition, these patients are always tired. They have non-refreshing sleep. So in the morning, they are already tired. And importantly, they have what we call post-exertional malaise, meaning that if they do something extra, that can be mentally, but also physically, they have the next day that they can't function at all. So they have to stay in bed more or less. They can't do anything. You have to fulfill these 3 criteria at least before we can say the patient does have ME or chronic fatigue syndrome. So what is chronic fatigue syndrome? It's a disease that is quite common. It's about 0.5% to 1% of the population in England. And it is a very disabling disease. So half of the patients cannot work, and 10% of the patients are laying the whole day in their bed. They're housebound. And the challenge is that doctors actually do not know what to do. And therefore, doctors quite often ignore the existence of this disease. So treatment in generally has been not very effective. It's mentioned that about 1 in 5 patients only have some benefit of the treatment. And until, say, 5 years ago, there was not much research ongoing. It's difficult to do research because there are many different subgroups, and there was not much known about the pathology. So I mentioned already that patients are tired, but they have more. They have sleep disorders, they have cognitive impairment, they have often muscle and joint pain, they are sensitive to light, They may have IBS, so irritable bowel syndrome with stomach pain, bloating, nausea. They have quite often swollen mucosa in the sinus and swollen glands, and of course, very important, they have that post-exertional malaise, which is by definition must be present. So you can look at it also in a different way. There are many different complaints, also interstitial cystitis, meaning that they have constantly the feeling as if they have a urinary tract infection, but we can't culture bacteria. Orthostatic intolerance is a very prominent symptom. That means that if patients get quickly up, their heart is racing and they're dizzy. So those are all kinds of symptoms that we encounter in this syndrome. So it's really a systemic disease with, until recently, not much known what it caused. I'm here. I am actually an internal medicine specialist who trained in nephrology, so in kidney disease, but I became chair of immunology in Maastricht in the Netherlands. And because of my gray hair, they said, well, you have to retire. So that's when Canada came in, because here in Canada, there's no age discrimination. So I was allowed to continue my job here, and I was asked by the chair of the department of medicine to whether I would like to be the director here in rheumatology. And in rheumatology, we more see patients with fibromyalgia. So that's actually, it's not exactly the same as ME/CFS, but it has a lot in common. So many patients with ME/CFS, I told you already, had muscle pain and joint pain. The other way, fibromyalgia patients quite often have fulfilled the clinical criteria for ME/CFS. So it's a spectrum. So first of all, I mentioned that I was dissatisfied with what I did for the patients with vasculitis. So we got a big grant from the Dutch Kidney Foundation, and because patients in Holland, they said, well, the most important thing for us is not find a new drug now. The most important thing is get researchers work on fatigue. So they gave me a nice large grant, and the University of Alberta helped me as well to see what's going on. And first of all, we looked at our patients here, and we looked how many of our patients that were very well treated, did not have any disease activity anymore, still had this very disabling ME/CFS. And it's about half of our patients do fulfill the criteria. So that indeed fit with my frustration that that there are so many patients who actually are well treated, but actually are not that satisfied with the outcome. We went a little bit further. We looked at different other diseases. We have a lot of patients with systemic sclerosis. It's also a very difficult autoimmune disease. Unfortunately, a disease where we still don't have a very good treatment. So if patients are severely ill, we do bone marrow transplants. This is a disease that's not well treated with prednisone and with other immunosuppressives. And there also we found that about 2/3 of our patients have ME/CFS, and they have that already very early in the beginning, before they have a lot of symptoms. So as mentioned, in our cohort vasculitis, about 50% have ME/CFS. And recently we also looked at the lupus patients, and also for lupus, we found that it's about 50% that fulfill the criteria for ME/CFS. Rheumatoid arthritis is still on the program, but we think that there's also quite often ME/CFS. We think it's lower than in the other diseases, though. So we published on that, and we went further to see what's going on, what may be the cause. And as mentioned, these are the symptoms. So the most important symptoms are the fatigue and the post-exertional malaise. and also the sleep disturbance, but they also have that clear brain fog with problems with thinking, memory, and executive functions. And they have that orthostatic intolerance quite often, so that when they quickly raise, they're dizzy. So it makes sense that if you're so tired, to look at the mitochondria. Mitochondria are the plants in the cell actually that make energy. So if the mitochondria don't work, you can imagine that you're tired. So first of all, sorry, this is something we also did. So we looked also in our patients, how often do they fulfill the criteria for fibromyalgia? And there we found that in the vasculitis group, we found that 1/3 of the patients did have fibromyalgia, and all of them had also ME/CFS. So what about the mitochondria? So the mitochondria are machinery that finally makes ATP. ATP is the energy that a cell needs. So looking into that, we found that in patients in systemic sclerosis especially, we found that there's a clear abnormal signal in the mitochondria in those patients who have that fatigue. So indeed, the mitochondria are affected in patients with vasculitis. That's the yellow, what you see here, and the systemic sclerosis, which is the gray one. So they're clearly different than healthy people. And if we look at a different way, we can see that the DNA of the mitochondria is damaged and that the repair mechanisms don't work very well in those patients who are tired. But it works well in the patients who are not tired. So from this first study, we concluded actually that if we look at patients with autoimmune diseases like lupus, like vasculitis, like systemic sclerosis, and probably also many other diseases, there's a subgroup of patients who already in the beginning of their disease manifest with severe fatigue. And we think, and we have some data now, that this subgroup of patients actually have a worse prognosis. They have more severe disease during follow-up. So it's not only the fatigue that's actually puzzling us, but also that if we have a possibility to treat that fatigue, that maybe the prognosis for the disease is also better. And for this research recently, Charmaine van Ede, who is working in our lab, got a big prize in the autoimmunity conference that was held this year in Ljubljana in Slovenia, beautiful country. So from this first part, we could say, well, fatigue, as in ME/CFS, occurs in many systemic diseases. The pathophysiology is still not completely understood, but it's clear that there is mitochondrial dysfunction. Another group of patients that I am seeing are the patients with implants. So about 30 years ago, we started seeing patients with implants that developed autoimmune factors. And it's long been debated whether this is a real disease. But lately, more and more groups now recognize that there's something ongoing. Many patients that I see have breast implants and have become ill after their implants, but there's also patients with mesh implants. Some patients have injections in the buttocks. with materials. Fillers also sometimes can do it. But also arthroplasties, like a hip implant or knee implant, can sometimes cause such a disease. And also sterilization with certain metals can do that. So we call that disease ASIA. It stands for autoinflammatory / autoimmunity induced syndrome induced by adjuvants. Because these implants work as an adjuvant. An adjuvant means that it helps the immune system to get activated. We use adjuvants always when we do a vaccination, because if you inject just a protein, nothing happens. If you inject a protein in combination with an adjuvant, then the immune system develops and can produce protective antibodies, as with the COVID vaccine or whatever. So what are the characteristics of this disease? Well, also these patients, they are very tired and they fulfill the criteria for ME/CFS. They generally also fulfill the criteria for fibromyalgia. They have brain fog. Typically, they also have very dry mouth and very dry eyes, as we see in Sjögren's disease. They have pyrexia, meaning that they're having these feverish feelings. And they have MS-like attacks, meaning that they sometimes have just suddenly an arm that is totally numb, or that they can't see for a short period. And importantly, they develop a lot of allergies and or autoimmune diseases after their implant, and their immune system is clearly deficient. So this is a specific syndrome induced by adjuvants. And as you may know, there's a lot of publicity around breast implant illness, which is a name that they use here in Canada and in America. In Europe, we prefer actually Asia, but okay. And there's a lot of debate, especially plastic surgeons. They say, well, you can't be ill from implants. And also gynecologists who put in mesh are also a little bit reluctant to recognize that they did something wrong to the patient, which is understandable because that's their daily work, and you promise to do good and not bad things to a patient. But we definitely think that it is a real disease. And here, for instance, you see some convincing studies that we recently did. If you isolate RNA from these patients and then compare it with normal healthy controls, you see here that there is a clear difference between the normals in green and the abnormals in red. So we can differentiate just by looking at RNA samples of these patients to say, okay, this is really something different than what in healthy control. So it is a separate disease. So I told you that ME/CFS is not the same as fatigue. Fatigue is much more severe in the ME/CFS, and ME/CFS can go ahead with fibromyalgia. And it is important to recognize this as a separate group of patients. So it's always difficult to find money for such things, because half of the world thinks it's nonsense, it doesn't exist. And researchers always love to do genetic studies in very well described diseases, but such a fake thing as ME/CFS, it's difficult. So we were actually happy with COVID, because now suddenly there were lots of patients who developed long COVID, and it was not only the same patients that were having ME/CFS, but it now was a lot of doctors and nurses, because we were the ones who were exposed to the COVID in the beginning of the virus, totally unprotected. So many healthcare workers actually developed long COVID. So it was a little bit easier to get money for that. So we did do a lot of studies together with the Professor Elahi on long COVID. And in general, we have had 4 groups. One is a group of healthy people. And then we had patients who had acute COVID infection. We had a second group who actually developed long COVID. And also here we selected for those patients who had long COVID that fulfilled the criteria for ME/CFS. So it was not that they have after COVID a little bit of a long-term problem with tasting or something like that. No, they were severely ill after the COVID infection. And we had patients who totally recovered from the COVID. So we had 4 groups and we studied this, and we could do nearly everything you can think of. So that was great. We could do immunophenotyping, we could immune cell function research, we could measure all kinds of cytokines, chemokines, and other biomarkers. We could do metabolomics, and we could do an RNA-seq. And I want to highlight this because here we really learned a lot about what it is when you develop ME/CFS. So this is basically our objective. We want to see whether we can look who's at risk. We can do mechanistic studies, and we hope to find therapeutic interventions. As you know, there's no treatment yet for chronic fatigue syndrome, not from the other diseases, but also not for long COVID. So first study, we had 40 patients. Only a very small group of these patients, only 4 out of 40, had severe COVID that needed intensive care treatment. So most of the patients did have mild COVID. They weren't in the hospital. 70% not only had ME/CFS, but also fibromyalgia. 70% had clear cognitive failure. 3/4 of the patients did have sleep disturbance. 1/5 of the patients did develop actually an autoimmune disease with inflammatory arthritis. And some patients did have anxiety and/or depression. Remarkable, about half of our patients did have autoantibodies, which may be different autoantibodies. ANA, which we use for lupus and systemic sclerosis, was positive in a subgroup. Rheumatoid factor was in a subgroup positive. CCP, ANCA, as mentioned, my autoantibody, antimitochondrial antibodies, and thyroid antibodies were present. So it's clear that their immune system is disturbed because they didn't have that before the COVID infection. And this is then what we present generally. So it's a little busy, and I won't go into this detail because it's too difficult to see all these small letters. But as you can see here, there's all these studies that we could do in our patients. First of all, we do immunophenotyping. So you look at what cells are there and if there is a relation between the cells, certain cells, and different clinical factors. And the clinical factors, we all do these validated questionnaires. So we have a validated questionnaire for fibromyalgia. We have a validated questionnaire for fatigue, and we have a validated questionnaire for cognitive impairment. And what you see is that when we looked at all these cells, that especially the naive CD4 cells closely related to fibromyalgia, fatigue, and cognitive impairment. So the more naive cells you have, the higher these indexes were. If we go ahead and do the metabolomics, we also have such a picture that um, uh, um, we could look at the long COVID patients, and remarkably, and that's often found in all our studies when we look at ME/CFS, is that about 75% of the patients are actually female. So long COVID, but also ME/CFS and other factors are much more common in females. So first of all, and that shouldn't surprise, we found that patients with long COVID had lower ATP levels. ATP was the energy that's made by the mitochondria. So that's a first statement that fit with our ID. They don't have enough, the mitochondria don't make enough energy, so therefore patients could be tired. These are difficult studies, as you can see. So this is result that we have. So here you have there you have the, say the healthy controls. Here you have the acute patients. Here you have the recovered patients, and here you have the long COVID. And then what you do is you make a heat map. You can look at all these metabolites, and you see clearly that the colors are different. That's the only thing I can show you here. But more importantly, if we look then further, we can really differentiate the different groups. So these are the acute patients. These are clearly different, but also the long COVID patients are different from healthy controls and recovered patients. And if we then look at so much metabology, you see all these kind of factors. Importantly, we found that serine and sarcosine were both lower in the LC group than in the other groups. Why is that important? Because we found that these two amino acids were actually very good correlated with cognitive impairment. So that makes the idea that makes the idea from maybe we could substitute patients with sarcosine and or serine to see whether we could improve the cognitive impairment. And we have now a small pilot study, and I think we have now 8 patients, and I think 6 out of 8 clearly improved cognitive impairment while using supplementation with these amino acids. So that's something which is, I think, promising. Have we do all these scoring systems with the MoCA score and with the cognitive failure score, and see indeed that there is improvement. Another thing from the metabolomics was a protein called artemin, and artemin is maybe a very good biomarker to differentiate patients who have long COVID from healthy controls. So as you can, we then make these kind of ROC curves, and you can see that about 95% of the patients who have long COVID have elevated levels of artemin, and it's not totally specific, but it has some specificity, and you can improve that even with different methods. So here you see the levels of the artemin in the long COVID much higher than in the recovered and the healthy controls. So we may have found a biomarker for long COVID. Another important biomarker is probably galectin-9. It's less sensitive, but even much more specific. So it comes to a specificity of 100%, meaning that if you do find elevated levels, all our patients actually had long COVID. although it's less sensitive, although there's 20% of the patients who do not have the elevated artemin levels, galectin-9 levels. So we come up with these kind of schedules. What we found in long COVID is that there is many different cytokines that are produced and are elevated. We did have a discovery cohort and we had a validation cohort. But a very general thing is that galectin-9 is upregulated. And we think now we have some proof that the galectin-9 is especially produced when the tissue is ischemic. So when there is not enough blood coming in tissues. And that's a central idea now in chronic fatigue syndrome and in long COVID. Another very important factor is that we found that the sarcosine and the serine, these amino acids, are not as high as they should be in healthy controls. And that's because there is probably a leaky gut. So we think that there is persistence of COVID virus in the gut, so that the gut is leaky, and it actually inhibits the possibility to absorb sarcosine and serine and other amino acids. And that's one important hypothesis as well. And the other important hypothesis was, as mentioned, the galectin-9 induced by ischemia of the cells. So is it true that this virus persists? There's a Belgian group who actually reported from Leuven that in long COVID patients, this virus can persist in the circulation. So we looked in our cohort, and here you see the results. We can find the virus sometimes in the blood of acute patients, but never in our cohort with long COVID. So no, our answer is no, there's no persistence in the circulation, but the persistence is only in the gut. So lately, we also published the results, or it's actually next year, but it's already online available. The results where we did do the RNA-seq. I told you that RNA-seq we did in the breast implant patients to prove that it's a real disease. So here we did do the same, and also here we clearly could see that there's difference between the controls and the long COVID patients. So here you see also two groups, they're completely different. And there's 413 genes that are upregulated and 196 that are downregulated. So you get these kind of pictures. Difficult to interpret, but you also here can pick just every gene and see what they're doing. So that's what we did. And we did look at the top 10 genes that are upregulated. And importantly, most of these genes were involved in neuronal injury response. So they're important, we think, for cognitive dysfunction. And from these genes, we selected one, the RELN gene, that produces the RELN protein. And then we looked at the protein in the blood compared to the healthy controls. And also here, you can see that if the protein is elevated, that is clearly in those patients with long COVID and not in healthy controls. And here we have also good prediction of who is going to have long COVID. So that's another marker. So we found galectin-9, we found artemin, and now a new one, relin, which is related to probably to cognitive dysfunction. And what are the top 10 genes that were downregulated? So that was a little surprise, but we could actually predict that maybe, but still it was a surprise. So the olfactory receptor genes were downregulated, and if you look then at these genes, here you see two different olfactory genes. You see that in controls it's much higher. So olfactory genes, of course, are important for taste and smell. And we know that in the acute phase, there is an issue. And some patients with long COVID indeed have long-lasting issues with smell and taste. So what we found is now that there's lots of things going on in ME/CFS when it's after long COVID, but probably also in other patients with ME/CFS. So if you look at the genes, we've found various pathways that were not working well. We discussed renin, artemin, and galectin-9, but also if we looked at the cells, we found that the memory cells, memory CD4 were related to brain fog and fatigue, but we also found that the regulation of the immune system is impaired and the NK cells are impaired. NK cells are very important for fighting viruses, but also very important for after the virus is overwon, that the immune system then stops working so hard. And so you know that especially young people with COVID-19 also could die from the COVID infection just because they developed a cytokine storm. So the immune system didn't know how to stop anymore. And that's basically because your natural killer cells don't work well. So there's different things also from the literature that we know. So there is, in many patients, autoimmunity, there's autonomic dysfunction, there's certain autoantibodies to GPC receptor that are not functioning well. There's neural inflammation, there's decreased amino acid uptake, and that's also very important for the what we call the kynurenine pathway. So and a leaking gut. So here you see a beautiful picture from a very important paper which was produced in Cell, which is the best journal that we can publish in. So what you see here is that there's persistent viral infection in the gut. Then there's persistent interferon produced, and that means that these platelets are calculated, and that means that there's less serotonin in the circulation, because tryptophan can't be taken up in the gut, and that means that there's less serotonin. Serotonin then influences the nervus vagus, so that there's cognitive defects. So serotonin is of course an important target because you can target that with medication. There's many serotonin uptake inhibitors that are used for depression, but here it's a different approach. Here you increase the serotonin in the circulation, and that's been tried in long COVID indeed. So as mentioned, there's virus persistence in cells, especially the gut. There's tissue hypoxia. We think actually that the hypoxia is mostly due to clotting and platelet dysfunction. I showed you that, as expected, there's less ATP produced, and there's chronic inflammation with a lot of immune activation and even complement activation. So what does it mean for treatment? Now I go first for long COVID treatments. So there are many different trials ongoing. We don't have a final treatment. So immunoabsorption, so you take away all the autoantibodies. That's been successful in Berlin. You see here, for instance, a first treatment with that, where patients were scored for physical function. And you see that after the treatment, many of the patients did have some improvement. There are studies with drugs that are being used against clotting. So rivaroxaban, in England, there's a study. There's colchicine. Colchicine is generally used for gout. It's a very strong inhibitor of neutrophils. And it's used there's a study in the Netherlands and in the UK. And then there's studies with serotonin receptor uptake inhibitors. That's in the Netherlands. There's a metformin study. Metformin is being used for diabetes and is an important drug that influences the mitochondrial function. And there are these histamine receptor blockers. So basically, because the mast cells are activated and patients may develop allergy problems. And there's 2 trials in the United States where they try to inhibit the virus further in long COVID. Here's one thing I would like to address. So I mentioned that serotonin in the circulation is deficient in these patients. Serotonin is not only important to be happy, but also for sleep. So serotonin is one of the precursors of melatonin. And so a Dutch group actually tried different SSRIs, so the drugs that are being used for having higher serotonin levels. And they indeed found that many of the long COVID patients did do well with these drugs. In rheumatology, we especially use SNRI drugs, so Cymbalta or duloxetine, which is not only a serotonin but also a noradrenaline receptor blocker. So, what does this mean for my approach? And you may have seen the picture which you can see in the behind. I'm a great grandson of famous Dutch painters, so I love always to have some art in my talks. So here you see fibromyalgia and fatigue. These are 2 Mexican painters. One is very well known, Frida Kahlo, but the other is much less known. But they all suffered themselves from fatigue and chronic fatigue syndrome. So what is my approach? First of all, I give patients high-dose vitamin D. Furthermore, I try to improve sleep. So saying we measured in Maastricht quite often melatonin production, which is quite difficult because you have to spit out every hour saliva, and then we measure the melatonin levels. I don't think anybody can measure that here in Canada, but in the Netherlands we had it running. And then what we know is that many patients with chronic fatigue do have what we call late phase melatonin production. So normally my melatonin level goes up at 8 o'clock, and then 10:30, 11 o'clock, I fall asleep. These patients, generally, if you measure it, they have very high melatonin levels early in the morning. So your sleep hormone tells you then, no, you have to go sleeping instead of waking up. So what we do is we do melatonin hormone replacement therapy. We give patients 3 milligrams 3 hours before sleeping, and they have to try that for at least 2 months before we say that it's helpful or not. And it's not a sleeping pill, it's just hormone replacement therapy. For pain, we have that SSRI or Cymbalta, as mentioned. And we try very often low-dose naltrexone, which is been mentioned to be helpful in a lot of patients. For IBS, we generally say try the FODMAP diet. So FODMAP diet is that you avoid sugar, dairy, gluten, and fructose. So you can't eat nearly nothing. But you can also do it the other way around, that you just look, say 2 months no sugar, and then 2 months no gluten, or 2 months no dairy, and then see whether your complaints improve. And since the gut flora is abnormal in patients with fatigue, we give them a short course of probiotics, especially VSL3, which is a Swiss patented probiotic that we use. In Canada, it's called Visbiome. And then many patients do have orthostatic intolerance. So we mention you have to really drink 3 liters of water or fluids per day and use sufficient amount of salts. And then if that's not sufficient, we give them a very low dose of a beta blocker. And as mentioned, for the brain fog, we try sarcosine, which has a good effect. So now I will continue on vitamin D. So vitamin D, it's been proven to be effective in several studies that it improves fatigue, as you can see here. So different results. So one study didn't find it, but most of the other studies did. So it's also dependent on what dose of vitamin D do you use. So this comes actually from our research that we did in multiple sclerosis. So first of all, Jo Smolders was a young student who came to me and he said, well, I want to study vitamin D in MS. So I said, okay, let's make a program. So first of all, what he did is he looked at the relation between how good the regulatory T cells work, so how good the regulation of the immune system was in patients that are low in vitamin D versus those are having good vitamin D. And what you see is that the regulation in those patients who have high vitamin D levels is good, but that the regulation is very poor when you have low vitamin D levels. So we postulated then, okay, so vitamin D can regulate the immune system, Tregs. And what does that mean? So if you have few Tregs, if the immune system is not well regulated, you have a huge imbalance between Th1 cells and Th2 cells. So that results in inflammation. So if you can improve that, the balance, then you get amelioration, then it goes better. And so the first study is then, is it safe? So that's the study where we looked at a high dose of vitamin D, so 20,000 units every day. And what you see is that vitamin D levels are sky high then, so don't measure vitamin D levels, not important. But you should look at calcium levels because high calcium, of course, is not good. It's dangerous. But here you see that during this 24-week studies, we didn't find any patients with high calcium levels. So that was safe. There was no hypercalcemia. And the other thing is we also looked whether there's too much calcium in the urine because that might be relevant for getting kidney stones. And also here, this is the level. And then you see that the ratio was never higher than 0.8, which is safe. So from this short study, we say, okay, it's safe to do high dose vitamin D. So now let's do a large study, multi-center, different countries. It's called the SOLAR study, where we had patients with multiple sclerosis. Multiple sclerosis is also a disease where patients are often very tired. So these patients were treated with interferon, and in addition, they got either high dose vitamin D. Now it's a little bit lower than in the others, but it's still high, so 14,000 per day, or a placebo. And this was a 48-week study. And importantly, what we found is that it was safe to do so, but also that patients who had this high dose vitamin D, in addition to their interferon, had much less new active brain lesions. So it's not only uh, uh, um, uh, a safe drug, but it's also an immune modulator. It's a cheap way of treating this difficult autoimmune disease, multiple sclerosis. But most importantly, these patients were also much less tired. And this was not only in the first year, but there's now studies where patients did have 10 years of follow-up. And you see that many of them still had these high dose vitamin D, and they had much better quality of life and were much less fatigued. So physical and mental quality of life improved actually with high dose vitamin D compared to placebo. Vitamin D works also for pain, we think. So pain is generally due to these neuronal connections, and there's also vitamin D receptors there. So the perception of pain is also influenced by vitamin D. And here's a small study from an Irish group where indeed, if you look at the patients with fibromyalgia and high dose vitamin D, and this is then 50,000 per week, and then you see that their scores for pain and the general score, how they feel, improves with high dose vitamin D. So go back to what we do. So although there is no proven treatment for chronic fatigue syndrome, it is my opinion that indeed I can do something for my patients. And I think my patients also agree, because many of them improve a lot with the treatments that we discussed. And the most important one of that is this high dose vitamin D. So what I do is I give them once weekly 50,000. Why do I do that? Because many patients then tell me, I take it on Sunday, I feel much better on Monday and Tuesday, I feel okay on Wednesday. And some of them say, well, but on Thursday, Friday, I need already more. So then we increase it to twice weekly, 50,000, which is still safe, but it has to be controlled. So don't do it on your own. There has to be checked for calcium levels, especially Dutch patients. So when I was in elementary school, we were forced to drink 3 glasses of milk every day. That was normal at that time in the Netherlands. We have more cows than people in the Netherlands, so they need to get rid of the milk, I think. But so many Dutch people are actually addicted to milk, cheese, and yogurt. And if you are, you have a very high calcium intake. So if you then take high dose vitamin D, your calcium may be too high. So you have to lower your calcium intake sometimes. So we still need more research, because especially we want to predict who might develop ME/CFS or fibromyalgia. And finally, our dream is, of course, to cure patients with ME/CFS and fibromyalgia. Finally, this is the group that did most of the work. So Dr. Elai is an immunologist here in Edmonton. And Dr. Osman is my brilliant co-worker. And Dr. Van Ede is the one who is doing most of the work in the lab. And we have the help of Daisy Ray, who's interviewing most of the patients with all the questionnaires. Lamia, who's working in the lab. She is also working helping in the lab. And Naima, fortunately, she wanted to become a doctor and stopped working at the research team, but she was a great help as well. And we are having many collaborated in nephrology and in rheumatology. And as mentioned, a lot of money was given by the Dutch Kidney Foundation, which I were very grateful for. That although I moved from the Netherlands to Canada, they still support me. And that's actually what I wanted to say. So questions, please. We wrote a chapter in the book that's recently come out about the causality between MASH and ASIA. And causality is difficult when you have an environmental factor to prove that the environmental factor is actually causing a disease. And this is the story about from Dr. Bradford Hill. You may have known his name. Dr. Bradford Hill mentioned in 1946 that smoking could cause cancer. So it was considered to be ridiculous, and that we at that time we had the Marlboro Man. Smoking was healthy.
Yeah.
You could get ill from it. It was the strong, healthy man who smoked. So Dr. Bradford Hill did not give up. So nobody believed him in the beginning, and then it took, I think, 18 years before the world was more or less more convinced. And he did that with 9 criteria. These are now called the Bradford Hill criteria. So what we did is we used the Bradford Hill criteria to prove causality for breast implants causing ASIA. And more recently, we published then mesh implants causing ASIA. And we used the Bradford Hill criteria. And I must confess, it's not as convincing yet as the breast implants. But I mean, the scientific world should accept the fact that there is causality. And it's always a matter of when is it proven. I mean, you know that when HIV was around, the virus that caused AIDS, there was a president of South Africa who actually ignored for a long while. And that's how the medical community sometimes is. They ignore things, especially if you are a surgeon and you put in mesh all the time. You don't want to hear people who say that they cause harm. So, but from a scientific point, you should follow the Bradford Hill criteria, and then you can prove that there is causality. So I don't know how it works finally in recognizing things. Do we recognize long COVID? Yes, I think we are more and more going to recognize it. But also there in the beginning, patients were hopeless, and the many doctors said, well, you have to train more, you have to do exercise. But if you have post-exertional malaise, you can't do exercise because then the next day you're totally exhausted. And that's been for years, especially the UK, they were horrible. They sent all these patients with ME, CFS to do exercise. So, and Australia is probably too much related to England, but you can say that our great grandparents did survive the black plague. And that's because their immune system was working well.
Exactly.
Nowadays, we have all these things that we put in we put a arthroplasty, and then your immune system is so good that they want to get rid of the arthroplasty. And that's what we call autoimmune disease. So yes, there is a common denominator. Your immune system should be better regulated. And there are very few drugs that regulate immune system. So vitamin D is one of the first been proven to have a good regulatory function inducing in very high doses. But the other one is, I'm an advisor from a Paris research group, but they are already more than 10 years working with it. So they use very low dose IL-2, which is also a regulator of the immune system. And there's now several groups in the world who are studying that. So there's a group in Germany, and a group in France, and a group in America who is trying to get better immune regulation. But that's a little more difficult drug than vitamin D, I must say, because it has to be injected, and it has some side effects. We had a very good patient group in the Netherlands. So in I think 2012, they started a petition for the politicians. So they said, okay, we need research, biomedical research for patients who are having chronic fatigue syndrome, or ME. And they had, I think, 86,000 signatures. And then politicians, they only do something if there's a huge group of people saying something. So the politicians finally said, okay, we believe this, so we need to do something. And then the Dutch Health Council actually was demanded to do something. And I was happy to join the committee that was then asked from what's the issue here? Is this a real disease? So then we came up with a rapport where we said, okay, there are many different systems not working well, and we really need to put effort in research. And finally, there's now about 90 million euro set apart for studying this disease, and it's really taken off. And of course, long COVID helped a lot, because there's also a huge pressure from long COVID patients that they need help. There is no treatment yet, but they need to do at least studies then to see whether the treatment can be improved. Unfortunately, we don't have the same money thing here in Canada, but there's a lot of initiatives of private people like our group, and there's other groups in Canada that's doing very good work. I would say that there are studies that high dose vitamin D help, and that he can contact me if he doesn't believe it. But and that it's not very important also to educate them that they shouldn't measure vitamin D levels, because if you measure the vitamin D levels, they become afraid because they're high, they're very high. And they're done. Generally, these labs have done red, and if it's red, GPs are woo. We should stop because it's red. That's not true. They should measure the calcium and the albumin and the phosphate. Those are the three markers of intoxication. But it's not intoxication due to vitamin D. It's intoxication because of the combination of calcium and vitamin D. Well, that's very true. So the recognition of the presence of ME/CFS in these different autoimmune diseases, that's really something we put forward. That we were the first to state that, and it isn't that exciting, but it's a new idea that is now gaining more and more knowledge or recognition in the world, that indeed our patients also. So it's more already talking about the neck pain. So also the neck pain. In the past, we also only treated rheumatoid arthritis just with the drugs that we have to treat inflammation, but more and more we know now that some patients do have what we call central sensitization due to the pain. And then we start with Cymbalta as well. And that's been more and more known that also in rheumatoid arthritis, we use those serotonin reuptake inhibitors. Fortunately, we learn a little bit as doctors.